Welcome to Brain Chat. I'm Dr. Mitzi Joy Williams, your board-certified neurologist and MS specialist, and my mission is to engage, educate, and empower those affected by MS to become an active part of their healthcare team. Here on Brain Chat, we'll be discussing all things MS, health and wellness, advocacy, and we'll even throw a little bit of music and music therapy in there as well. Thank you so much for joining us, and stay tuned for the next episode. Happy Monday, Brain Chat family. I am so excited to be back here with you all today. It's Dr. Mitzi, the nerdy neurologist, and my mission is to engage, educate, and empower those affected by MS and neurologic disease to be active parts of their healthcare team. So excited that you guys took your time out on Monday, on holiday, Juneteenth, to come and hang out and talk a little bit about a subject that I think affects many of us, whether people have MS or not, and that is migraine headache. It is Migraine Awareness Month, and I'm so excited about the wonderful guest that I have coming on tonight, Dr. Hope O'Brien, and I'll just introduce her in just a few minutes. You guys know how we do with Brain Chat. You log in and type in the chat and let me know where you are logging in from. I bid you greetings from Atlanta. Unfortunately, there were no parades or anything going on here because it was raining cats and dogs most of the day today. But I hope that you all had a wonderful holiday, and I hope that you all get something out of this exciting episode that we're having tonight. We also want to thank our sponsor, the National MS Society, for sponsoring Brain Chat, as well as the Joy Life Foundation. I hope that many of you caught the Black MS Experience last week, which was sponsored by the National MS Society. I did speak at that. If you did not see it live, then you definitely can see it online. So hopefully you'll go look in that. And for those of you who are in the New York area, the Joy Life Foundation is coming to the Big Apple. So this Saturday, on June 24th, we will be hosting an event at the Apollo Theater. And we are so excited to see those of you who have registered for the event. We look forward to coming to the Apollo and, spreading some knowledge and awareness with some of our patient advocates. We'll have Dr. Stephen Krieger there. We'll have Dr. Mary Hughes. We'll have Victoria Reese from We Are Ill. And we will also have Anne-Marie Johnson, who is a local advocate. So we're really excited to be coming to the Big Apple. But in the meantime, let's talk about these migraines. All right, so I'm going to introduce Dr. Hope O'Brien. She is our esteemed guest tonight. She earned her Bachelor of Science in Neuroscience with honors distinction in research at the University of Rochester. She completed her medical doctorate degree at the University of Cincinnati. And she also studied adult neurology at University of Cincinnati. She then went on to do a headache medicine fellowship and was recruited there to start to work as the director of the fellowship program, as well as establishing a young adult headache program there for young adults. And it was a multidisciplinary clinic to approach headache management, which I hope to get into tonight, the multidisciplinary approach to managing headache. She has been appointed to several expert committees. She holds leadership roles with the American Academy of Neurology and the American Headache Society. And as of 2021, she opened the Headache Center of Hope. So she is the founder and CEO of the Headache Center of Hope. And welcome, Dr. O'Brien, to Brain Chat.
Oh my gosh, thank you so much. It's such a pleasure and honor to be here with you.
Awesome sauce. Okay, so let's talk about headaches. Now, we could spend a lot of time talking about headaches, but I think that this is a really important topic, as it's something that I see not only in my patients with multiple sclerosis, but there are lots of patients who come and see me just for headaches. And I don't say just as if that's not a big deal, but that is the primary symptom that they have. So, we talked about Migraine Awareness Month. Before we get into headache, tell us a little bit about yourself and how you got interested in this field of study.
Yeah, so first of all, that introduction was great. Thank you. So I'll just briefly say that I am a New Yorker. I was born in New York. My parents are Jamaican. So for Juneteenth, I'm wearing my Jamaica t-shirt here.
Love it.
And I came into headache because as a resident in neurology, I saw a lot of patients who came in with headache. And what I found was depending on what faculty that you were working with, there was a different diagnosis and approach to a very common complaint. So I
Mm,
decided after finishing my residency to do a fellowship in headache medicine. And particularly, I wanted to follow patients very, very early in the disease. So
mm,
when we saw them in our neurology clinics, they were sort of older patients in their 30s or 40s, and I wanted to really see where migraine began. And if you talk to a patient, they would say, well, I started having headaches as a teenager, maybe
mm.
around my menstrual period. So I did a combined pediatric and adult fellowship through Cincinnati Children's Hospital and the University of Cincinnati. And from then on, just continued my career focusing on that condition.
Yeah, and I think it's so important. There's a key word you said there, and you said disease, right? Because when we think about headache, sometimes people don't think about it as a chronic condition. And there are many people that do have chronic headaches that impact their daily life, their ability to work, their ability to function at home. So, it's not always as simple as, oh, I just had a headache and I went and laid down. Like, this is often a condition that sticks with people for many, many years or for a lifetime. So, I'm really glad you brought that out. So let's talk about what is a migraine. Now, every time I talk to somebody like, oh, I had a migraine, I had a migraine. What is the clinical definition of a migraine headache?
Well, as you mentioned, Dr. Williams, June is Headache and Migraine Awareness Month, and this is our opportunity as providers who care for patients to spread the word about migraine, that it exists. It's a complex neurological condition that has symptoms such as moderate to severe pain.
Mhm,
Typically, we think about a migraine, we think about a one-sided headache, but it can involve both sides of the head. The headaches tend to be throbbing or pulsating in nature, lasting anywhere between 4 to 72 hours or longer, and associated with other symptoms such as light sensitivity, sound sensitivity, nausea, or vomiting. The
mhm,
headache can be worse with exercise or activity and then feel better when you're resting. So, those are really the classic symptoms of migraine. It is a clinical diagnosis, meaning you don't need to have any imaging or lab tests for the condition, but it's based on a family history, as well as some of the symptoms that I mentioned earlier.
mhm. Yeah, so, oftentimes, what we learned in residency and training is that people with migraines wanna go lie down in a dark, quiet room when they have a headache. That kinda, gives you a clue that there may be a migraine afoot there. So, thank you for that definition. And what about things like sinus headaches? Are those migraine headaches?
Oftentimes, patients will come to me and say, yes, I have migraine, but then I have all these other headaches too that are more sinus headache. And when you look at it, when you look at the research in patients who've been diagnosed, whether self or by a provider with sinus headache, they're very similar to what a migraine headache feels like. So it's sort of it can be in the center of the face or on the front of the face. Typically, with a sinus headache, though, patients have a lot of copious fluid coming out of the nose, a
Mhm,
lot of congestion,
mhm,
and you need an antibiotic to get rid of it. Whereas
mhm,
with a migraine, oftentimes patients will say, well, I took a sinus medication. And if you think about it, some of the medicines that we actually use for migraine help to work on those same receptors as a migraine. So,
mm.
oftentimes, if you think you're having a sinus headache, if it goes away in a day or in hours, or if you take a medicine and it goes away right away, that's not an antibiotic. It's most likely a migraine.
Mm. Excellent, excellent advice. Okay, so we have some information about kind of what the definition of a migraine is. Are there triggers for migraines? Do we know what causes migraines? Like, so some people get them, from teenage years. Some people have a strong family history of migraines, some don't. What do we know about the cause of migraines?
So we know that the cause is quite complex. We know that there's a genetic predisposition,
Mhm.
meaning that if you have a parent with migraine, then your chance of having a migraine is 50%. So we know
Wow.
there's that genetic component. And then there's also environmental factors, meaning there are certain types of conditions, whether there's weather changes or hormonal changes, changes in your eating, sleeping that can trigger migraine, maybe caffeine. So we know that in somebody with this genetic predisposition, then you are more likely to get a migraine in certain conditions.
Wow. So, so there certainly can be a genetic predisposition. And what about once someone has, had a history of migraine? So, at what point do you call it chronic? Do you have to have a certain number of headaches over a certain number of years, or is it just if you have those typical headaches, you have a migraine condition? So, how does that work?
Yeah, so the definition of migraine is based on the International Classification of Headache Disorders. And the
Hmm.
symptoms I talked about, you have to have at least 5 attacks in a lifetime.
Gotcha.
If you've had 5 attacks in a lifetime, then you have the diagnosis of migraine.
Okay.
Okay. Then, in terms of the frequency of migraine, what distinguishes one from chronic versus episodic is the frequency.
Mm-hmm.
So, if you're having 15 or more headache days per month, of which at least 8 of those headaches are migraine headaches, then you meet the criteria for chronic migraine. Any frequency less than 15 headache days would put you in the category of episodic migraine. So there
Mm-hmm.
are patients who, let's say, may have 2 to 3 headache days per month. They would be known as an episodic migraine patient versus individuals that are having 15 or more headache days would be known as, again, chronic migraine. And that's important because based on
Mm-hmm.
your frequency, you would then qualify for certain types of treatment.
Mm. Yeah, and we're going to get into treatment a little bit later, but I want to dig into that a little bit more. So you said something interesting there. You said you have to have a certain number of headaches that are migraine headaches. So do people with migraines also have other headaches as well?
Great question. So,
Mm-hmm.
headache is a symptom of migraine. It doesn't tell
Mm,
me the cause, right? So, having a
mm,
headache is, if you say you had a belly ache, it doesn't tell me the cause. If you had a fever, it doesn't tell me the cause. So, headache is just a symptom of the migraine. And so,
wow.
as a headache specialist, my job is to categorize that headache. What kind of headache is it? And what is the cause of that headache? And the most common cause of headaches that I see in my clinic are migraine because it's so disabling.
Mm,
It affects over 40 million patients or individuals in the US,
wow.
over 1 billion worldwide. So it's the
Wow.
most common type of headache that a patient will come in complaining of.
Hmm. Yeah. And I think this really important to recognize that because headache is one of those symptoms that you unfortunately can't see, right? So for instance, if someone has weakness, you can see that if they're dragging a leg. But headache is a symptom that really can be disabling, but it's something that we can't necessarily visualize unless we see someone that just doesn't feel well. But we sometimes can't wrap our arms around, that person having that severe of a headache. Um,
Yeah.
one other question. There are some people with migraine who have what we call an aura and some who don't. What is an aura?
So, an aura is a warning sign that a headache is about to start or the migraine is about to start. It affects
Mhm,
30% of patients. The most common type of aura or warning sign is changes in the vision. So,
mm,
patients, they say they see flashing lights or squiggly lines. They may look at patterns and they look like they're jumping. They may also see maybe a shadow coming through, or maybe their central vision may be blocked out, or their peripheral vision would be blocked out. So those are some of the common changes, vision changes that patients will get before the migraine will occur. And it typically will last up to about an hour.
okay. And it'll occur. Now, it can occur. Does it always occur with the headache or can it occur without the headache?
So that's a great question. So the most common that we see is that it occurs before the headache, but you can have aura that occurs during and even after the headache as well. And there are
Okay.
patients who have the aura without the headache. We
Okay.
call that migraine aura without headache.
Okay, gotcha. Very self-explanatory there. All right, and one more thing before we talk about a couple other different types of headaches. Um, what about triggers? So you talked a little bit about weather changes, barometric pressure. What are some of the common triggers for migraine?
So I will tell you that patients will come in and will say that certain foods may trigger their migraine, whether
Mhm.
it's eating chocolate or red wine
Oh,
or aged
chocolate. Oh
cheese or
gosh.
nitrates.
Woo.
But I will tell you that this is an area of study in terms
Mhm.
of what is a trigger versus what is a prodrome,
Mhm.
meaning what are certain symptoms that patients will get before the headache phase or the aura phase
Mm.
of the migraine. And so what we're learning in science is that, patients will have these certain cravings for chocolate or cravings for certain foods, and they may feel like that is actually a trigger for migraine when it may actually just be a prodrome of it. That being
Wow.
said, there are patients that say that every time they, let's say skip meals, they'll have a migraine. That
Mhm.
could potentially be a trigger. They'll say
Mhm.
that sleep deprivation, so not getting enough sleep, will trigger a migraine.
Mhm.
Or if they wake up and they don't get that caffeine, can be a
Mm.
trigger. And so what I tell patients is to, try to avoid what we know can trigger migraines, meaning try to avoid not getting enough hydration. So staying hydrated, watch your caffeine intake, and also making sure that you get adequate, consistent sleep, meaning
Mhm.
not staying up too late or sleeping in. What we
Mhm.
find is that it's the change in the brain that the migraine patient can't, or patients with migraine, excuse me, can't tolerate.
Interesting. Interesting. We'll have to come back to that program. Maybe we'll have another discussion about that. Very, very interesting. All right. So we talked about migraines, which you said are the most common type of headache. What are maybe the next two or three most common? For instance, some people have tension headaches. So can you talk to us about a couple of the other more common types of headaches that you see in your practice?
Yeah, so I will say that tension type headache is actually the most common type of headache, while migraine is the most common disabling headache that we see.
Ah,
So those
okay.
are the different. So the
Okay.
majority of patients do have tension headache. And
Mhm.
what that is it's very similar to migraine, except that the headache is more mild to moderate
Mhm.
and never associated with nausea and vomiting.
Mhm.
Those are really the key differences between tension type and migraine type headache. And I will say that there are patients who have both. They'll have a
Mm.
tension type headache where it's not as severe, and then
Mhm.
they'll have the migraine type headache as well. And some
Mhm.
would argue that the tension type headache is just a syndrome or on the spectrum of migraine.
Mm. Mm.
So we're still trying
Interesting.
to figure that out in the headache world.
Okay, so if tension may be a milder form of migraine, so
Correct.
one of the things that we love to do on Brain Chat is I love to educate people living with conditions as well as their families. When we talk about different types of headaches, we have common names for headaches, which is why I asked you about, sinus headaches. Hungry headaches, right? I heard up here about hungry headaches. So, you just discussed that sometimes sleep deprivation can be a trigger for migraine. So, sometimes if people are having frequent hungry headaches, those could potentially be a form of migraine. What about stress headaches? Are those tension headaches or migraines or a little bit of both?
So what I will say is that when patients make these descriptions, it's because they tend to find that they will get a headache after a certain behavior or when something occurs. So after stress, they'll get a headache, or
Mhm.
after they feel like it's in their sinus area, they call that a sinus headache. And
Mhm.
so those are really all migraine because migraine
Mm.
tends to occur when you are stressed
Mm.
out. And some patients will say that they feel kind of the pain sort of around their head, and will have all the similar features of migraine, or they may have not a strong enough headache, and so we call that more tension. But the definition of stress headache, or that really doesn't exist in terms of the medical world. And
Mhm.
it's important to say that because when you go to a provider, we need to categorize these headaches into a definitive diagnosis so
Right.
that patients are adequately treated. So you can call
Yeah.
it whatever. You can even go to your provider and call it that, but it's our
Mhm.
job to make the diagnosis. Unfortunately, migraine is so underdiagnosed.
Right.
Um, and we can talk about that a little bit later in terms of healthcare disparities, but it's so
Mhm.
underdiagnosed. And unfortunately, what happens is that the outcomes are worse in patients who don't have a diagnosis because they don't
Mm.
get treated.
Wow. Well, let's pause for a minute and let's go right into that, right? So I think that this is important, right? Because certainly, I grew up and people had all these names for different things, but they were never really diagnosed with conditions or treated. It was just, oh, I have stress headaches, or I have hungry headaches, or I have this, or we had all kinds of names for everything. But I think that it is important for people to put names to things, even if
Hmm.
they don't necessarily go on a medication, to learn how to deal with that condition, to know what you have so that you can adequately handle it. And I think that's extremely important. So let's talk about the underdiagnosis, right? And how there are healthcare disparities in migraine, just like there are with MS and many other conditions. Can you tell us a little bit about that?
Yeah. So what I will say is that unfortunately, migraine is underdiagnosed and
Hmm.
undertreated in Black or African American communities as well as the Hispanic communities.
Hmm.
So, for instance, Black and African Americans are 25% less likely to get a diagnosis of migraine, and also Hispanics are 50% less likely to get a diagnosis of migraine.
Wow,
In
50%.
terms of, I know the numbers are staggering. In terms of treatment, patients with migraine, Black patients, African American patients, are less likely to go to an outpatient facility for diagnosis as well as treatment. And then also, Black and African American and Hispanic or Latina population are less likely to be prescribed an acute medication for migraine.
Mm.
So with that, results worse outcomes. Now, as you mentioned, Dr. Williams, not everybody needs to be prescribed treatment for it, but as you mentioned, those stress headaches or hunger headaches can be given a name, and
Hmm.
with that, we can then tell patients ways to help lower the likelihood of getting these strong headaches. I will
Hmm.
say that Serena Williams, I had an opportunity to meet her, and she had migraine, and she's very public and open about it. She's had migraines for years and struggled with it even while playing, tennis. And she said she called them strong headaches. She didn't know what to
Hmm.
call it. And,
Wow.
suffered for years and years with this condition. And so I think, especially for those that are in underrepresented communities, and even in Native American communities, that we learn to identify it in those populations, so
Right.
that we can make a recommendation in terms of management.
Yeah, that's so important. I think that's why, raising awareness, so I'm glad we were able to do this during Headache and Migraine Awareness Month, because I think people do need to be aware, right? That you don't have to live in chronic pain without any help, and that is not normal, So I think that it's important, for people to know that they can be treated and they should be treated as well. So, going a little bit into before we get into treatment, because I do want to talk a little bit about treatment. When should people get concerned about their headaches, right? So, for instance, I have a family member. I won't say who. I was about to say my mama. Well, it's my mama. All right, mama, I put you out on Front Street. Has headaches, and she has severe sinus disease that's not treated, and so it's she thinks something is going on in her brain, right? And so there are times when people do have severe headaches, and it is a more severe issue, not just a migraine. It could be a brain tumor, or some type of hemorrhage or something like that. When should people get concerned about their headache symptoms and seek acute treatment?
That's a great question. And as a neurologist, my job is to, and as neurologists, our job is to make sure that we rule out any dangerous causes of
Absolutely.
headache. And so one of the things I'll tell patients is, if you're having a change in your headache pattern, meaning you've been having headaches for years, but now there's something very different about this headache, then you definitely need to be evaluated. If you are having any neurological symptoms, such as
Hmm.
numbness or weakness or changes in your vision or your speech or swallowing, you definitely need to be evaluated. If you're older, so it's very unlikely for migraine to begin after the age of 50.
Hmm.
So that's when we definitely want to see someone. And then I tell patients that if you have a headache and it just doesn't go away, you
Hmm.
need to be evaluated. Obviously, a very quick thunderclap, right away headache, very sharp, very strong, you need to be evaluated in the emergency room.
Hmm. Absolutely. And I think that that's also very important because, on the one hand, we want people to be aware that they can have chronic headaches, but then other times people are like, well, always have headaches. So when this one came, I didn't come to the doctor. And,
Right.
there may have been a poor outcome because they didn't go in enough time. So it's
Correct.
important to pay attention to your body. And if you're having something that's different than your baseline, or if you're having a new headache, or if you never had headaches and all of a sudden start having a headache, it never hurts to seek, some type of medical attention. So I think that's extremely
Absolutely.
important.
And I
All
just
right.
want to make
So
one more point real quickly
absolutely.
before we get away with that.
Yeah.
I would also talk to your healthcare provider or physician. I think it's so
Hmm.
important to be an advocate for yourself. Oftentimes, I know when you go to the doctor and you feel like they're in a rush, but really talk to them. If you are having headaches, please mention it, bring it up, because what we see
Absolutely.
is that, African American or Black individuals, Hispanic individuals, they actually report to the emergency room
Hmm.
for a headache, which ends up happening to be a primary headache, so more of a migraine as opposed to a dangerous headache, as
Hmm.
opposed to a condition that can be treated by your primary care doctor. So definitely bring it up, speak up and advocate for yourself.
Absolutely. I encourage folks, write that list before you go to that doctor's appointment, right? The top things that are concerning you, and make sure you get those addressed when you go to that visit.
Hmm.
And if they need to refer you to a neurologist, the neurologist also sees you for headaches, but certainly make sure you bring that to someone's attention so it can be addressed. All right, so let's talk about treatment. Now, this is an exciting time in neurology because the treatment for MS, as well as the treatment for migraine, has changed exponentially, right, in a very short period of time. So tell us a little bit about how we approach migraine and headache treatment once we identify the diagnosis. We'll focus on migraine because that's one of the most debilitating ones people have, and then we can, get into a couple of the other ones if we still have time.
Yeah, so I will tell you, it's an exciting time to be a neurologist.
It
It's an
is.
exciting time to be a headache specialist because over the last few years, there have been some new treatment options that have come out. So I will tell you that, migraine is one of those conditions where the first treatment came out back in the early 80s.
Mhm.
Prior to that, we were using what was called ergots, and they had some pretty significant side effects. And then in the 80s came the triptans, right? And so
Mhm.
these are migraine specific medications that are offered to patients to try to stop a migraine. But unfortunately, for some patients, there's side effects associated with that. And with this class of medications, there are patients who have contraindication because of cardiovascular disease.
Mhm.
Well, now we have these new treatment options that can not only treat or stop a migraine, but also prevent migraine. And that's
Mhm.
due to the investigation and realizing that these molecules called CGRP or calcitonin gene receptor peptides have come into the market. They've been proven to be effective with much less side effects for patients.
Mm. So that's really exciting. So are the treatments, what form are they? Are they pills? Are they shots or
Yeah, great question.
IVs?
Great question. So these medications come in pill form, they come
Mhm.
in injectable form. There's a new nasal spray formulation that's coming out, and there's also what's called devices. So we
Mm.
have now a wide range of treatment options for patients, not just orally and through an injection, but also devices are also out there.
So that's really exciting. So a couple of things. So when we talk about kind of the way we approach management of headache, I was always taught we think about, acute management, we think about prophylaxis for those that need prophylaxis, and then we have breakthrough management. Is that still the thinking of how we address migraine, and what do each of those categories entail?
Yes. So when I think about migraine management, I think about four tires on a car. The
Okay.
first the first tire is acute or abortive medication. So that's the medicine that you would take or the treatment that you would take to stop a migraine.
Hmm.
Typically, we tell patients not to overuse that. So like over the counter medications like acetaminophen or naproxen, and so we want to limit the amount of time that we use those abortive medications. Nowadays, there are some of the newer ones where you don't have to worry about taking medications too frequently, but that's the first class is what do you take to just stop a migraine attack when it happens? The second tier is prevention. So if you're
Mm,
having a lot of headaches, we talked earlier about chronic migraine. That's way too many headaches, especially if they're disabling and causing you to miss work or school or missing opportunities to be with your family members at certain events. So the preventive medications are medicines that you would take on a daily basis to prevent the frequency and severity of migraine and to get you back to not missing opportunities or missing work or school.
mhm,
The third bucket is what we call healthy habits. And so
mm,
those are things that you can start doing even now to lower the likelihood of you getting a migraine. So that includes making sure you stay hydrated, trying to avoid dehydration, making sure you're getting adequate sleep, but not too much sleep. So making sure you're on a consistent sleep schedule, making sure you're not skipping meals. Actually, skipping meals is one of the number one triggers for migraine, and then watching your caffeine intake. So too much caffeine can also trigger migraines. And then it's important to also keep active and keep an active lifestyle because that actually helps increase your endorphins and help you tolerate pain better. And then lastly is what we call biobehavioral,
mm.
meaning what kind of things can we do to help calm our systems, to bring ourselves to a state of rest and relaxations? What can we do to minimize or alleviate stress, whether that's biofeedback, mindful meditation, prayer, or going out and getting a massage.
Oh, so you're speaking my language. You're speaking my language. So yeah, so I think that that's important, right? I think a key is people recognizing that medicine doesn't do everything, right? So medicine certainly has its place. There are many therapies we've advanced, exponentially, in therapies in neurology, but it never gets rid of the part that you play in your own health, right? So doing those behaviors. I often encourage people, particularly when they first come to me for diagnosis, to keep a little diary because sometimes, particularly when you're talking about pain, um, you know, you may not be able, it hurt a lot, but you may not be able to remember everything that happened over the past 4 or 5 or 6 months. And sometimes just kind of jotting a note, maybe when you had a headache or a run of headaches, and seeing how that changes with those healthy behaviors, can encourage people to know that what I'm doing is making a difference. And so I think that piece about, healthy behaviors, but also, um, proactively trying to decrease stress. I counsel people a lot on meditation and mindfulness practices. We spend a lot of time talking about that, and tools to do those types of practices really helps overall health. So I'm encouraged to hear that that's also something that you counsel about with your migraine patients.
Absolutely. And
Yeah.
I will tell you that I will tell you there are patients who, and I always tell patients, migraine is not your fault. It is
Right.
not your fault.
Right.
So, keeping a diary, you can identify certain things that you can do and you can see how that improves, changing those behaviors improve your migraine, but also recognize that there are patients that they just can't identify
Hmm.
a trigger or a pattern. And so for
Right.
those patients, we want to make sure that we acknowledge them and try to
Yeah.
help manage as well.
Absolutely. Extremely important. Extremely important. And are there any specific treatments or have there been any treatment advances? Oh, also, let's talk about Botox, right? So we didn't talk about Botox. But it's very interesting because oftentimes when people hear Botox or botulinum toxin, they think about wrinkles, but there are actually many medical uses, for it outside of, tightening up places on your face that you want tightened up or loosening rather. Maybe loosening is the better because it actually paralyzes the muscles. All right. So when is that treatment used for headaches?
Yeah, so Botox or onabotulinum toxin is FDA approved for chronic migraine. So
Mhm.
you have to have that diagnosis of chronic migraine. So please don't go to your doctor and be like, you know what, I just need Botox because I have migraine. There
Right.
are certain symptoms, and it's based on the frequency of your migraine where you would qualify, and also the length of time that you've
Mhm.
had migraine for. And in a lot of cases, it is covered by insurance, but you do have to meet certain qualifications. I mean, you must have failed other conventional treatment options in order to have that covered by your insurance. But it
Mhm.
is definitely an option. I use it all the time in my
Mhm.
patients, as well as many of the other options that are out there. So the Botox is given once every 3 months, and it
Mhm.
involves 31 injections at minimum throughout the forehead, side of the head, back of the head, neck, and shoulders. But
Mhm.
also understand that there are injectable options as well. That's given once a month or
Mhm.
once every 3 months to
Mhm.
patients. And there's also the oral options as well. There's one
Mhm.
formulation that you can use to prevent migraine
Mhm.
every other day. And then
Right.
there's also a medication that came out recently that has a dual an indication for both episodic and
And
chronic
chronic.
migraine. So there's
Yeah.
lots of different options out
Yeah,
there.
so there are many options. And then you also mentioned something about devices. Can you tell us a little bit about some of the devices that are used
Yeah,
for
so I do
migraine?
have patients who come in who just don't want to be on medicine, and that's
Mhm.
fine. And so there have been devices that have come out that are wonderful in terms of the outcomes. There are devices, there's a device called the Neurologist device that you wear on your arm,
Mhm.
and that actually targets the trigeminal nerve that's involved in migraine. And that's been shown now to be to decrease the frequency and severity of migraine over time. So
Wow.
patients can use it not just to stop a migraine, but it can also be used as a tool to prevent migraine as well.
Mhm. Wow. So, I mean, it's just amazing how many advances there have been, just in such a short period of time. I remember when I was coming along in training, there were a couple of different medicines we could give, a couple of different pills, and we had our little 2 or 3 favorites, and that's what we gave everybody,
Yeah,
but it's really exciting to see that people have options, and I think people need to be aware of the different options, that are available.
yeah.
What about treatment for some of the other types of headaches? Like the tension headaches. Are the treatments the same? Can you use some of those migraine medicines for other types of headaches?
So I do want to point out that the medications that I talked about, these newer one, are indicated for migraine for patients with migraine over the age of 18.
Okay.
There are medications that we can use to treat tension type headache, and those typically are some of the over-the-counter NSAIDs or analgesics that can be used. There are medications that help with blood pressure that we use. There are certain medicines in the class of antidepressants that we use, but I just want to make the point that these newer ones are only FDA approved
For
for
migraine.
migraine.
Mhm.
That being said, I will tell you that the tension type headaches tend to be more of a lesser type headache and not so disabling, but we
Mhm.
still have those same conversations about lifestyle modifications and ways to reduce the likelihood. And one other important piece I want to mention is medication overuse.
I was
So,
gonna say that.
patients,
I was like, "Please talk about medications for my
medication
patients that like to
overuse.
pop that Tylenol 5 or 6 times a
Listen,
day."
Listen, if you're using an over the counter medication more than 3 days a week, you are overusing it. You should not be taking these medications every day. If you're using a combination analgesic, so that is your acetaminophen or your Tylenol, your aspirin, and your caffeine, if you're using it more than twice a week, you are overusing the medications. And what I mean
Mhm.
by medication overuse is you take this medicine like pretty much every day. And instead of the headaches going away or getting better, they're actually getting worse.
Mhm.
So if that's the case, please stop those medications and talk to your healthcare provider, your physician about that.
Yeah, and I think people aren't aware that sometimes that if you take those medications too much, it can kind of increase the headache cycle and make you start having more headaches,
Exactly.
because you're using those medications too often, and you really should be on something else for the headaches.
Exactly.
Um,
And it can occur not just in adults, but also in kids. And I
mm,
will tell you that there are medications that are FDA approved for kids. So the triptans, there are
mhm,
several triptans that are approved for kids because I don't want to
mhm.
forget about the kids.
Yes,
And then also the devices.
mhm,
So there
are
are
approved for
devices that are
kids.
approved for kids as well.
Well, that's good because I do have a lot of folks who start having headaches, as you said, in their teenage years or when they're, 9 or 10, they start having headaches. So
Actually, it's
extremely important.
interesting. For boys, they actually start having headaches earlier than girls. So
Really?
the average age for boys to start having migraine is around the age of 6, 7. For
Hmm.
girls, it's more like 10, 11. So a couple years before puberty. Yeah. So the prevalence of
Wow.
migraine is actually higher in boys than
Hmm.
girls. And then as one develops, it flips and it's more common.
Hmm. Wow. Do we think that that is due to hormonal changes or? Okay.
I think that's the theory behind it. Yes.
Mhm. Yeah, and have we always felt like migraines occurred this much in the population and they just were really underdiagnosed, or do we feel like we're living in a more stressful time where people are having more headaches and more issues, or maybe some combination of both?
I think it's a combination of both. I will tell
Mhm.
you that it's definitely a migraine is an under-recognized and underdiagnosed condition. And I will tell you, there's stigma behind it.
Mm,
People don't really want to talk about it, and people are actually suffering in silence, so to
mm,
speak. So they have the condition, but they don't want to talk about it or tell anybody about it. I'll give you an example. I had a patient who came in, and she is someone who is an executive at a hospital,
mm,
and during COVID, where everybody was confined to home and having these Zoom meetings, she would literally have migraines and would lay down in bed and turn her camera off and go through the meeting with a severe migraine and not tell anybody about it.
mm,
So over and over again, I have so many patients who have it and they just don't talk about it. I think now with some of these newer agents that have come out and they're advertised on TV, people are
mhm,
recognizing, oh, I have a condition. Oh, that's
mhm,
what that is. And now that are seeking help. But like I said,
mm.
over 40 million patients in the US.
Wow. Do you think the stigma is that people just don't wanna talk about pain, or I do actually see, some folks who come in and say, "Well, I tried everything already and it didn't work, so I just gave up." Do you think that those are reasons that people don't wanna talk about their headaches, or
Yeah, I think so. I think people don't want to talk about it because there's sort of this sense of weakness associated with
Mm,
it, and
mm,
because the headache symptom is so common,
mhm,
people will feel like, oh, well, if I complain, that I'm not tough enough to tough through the pain,
mm,
or people just don't understand what
mm,
migraine is and can't understand how disabling it is and that it is associated with nausea and people vomit.
mhm,
People are, because you can't see the condition
mm,
and there's no tests that you can do to confirm it. I would
right,
even say there are physicians who struggle with making the diagnosis because they
mhm,
don't recognize it or believe that it exists.
mm,
So yeah, I think by educating patients and by educating providers in terms of having patients go and talk to their clinician about this condition and that it's really impactful to them will make
yeah.
a difference.
Yeah, I think that's extremely important. So, as we are kind of coming toward the end of the show, tell us, what advice would you give to patients or to people out there who are having difficulty with headaches? Oh, one thing I wanted to talk about before we go into that. What about I've had quite a few people that have developed migraines post COVID-19 infection. Is that something that you've seen in clinic as well?
So that's interesting. So headache is a very common symptom of
Mhm.
COVID infection. And
Mhm.
so what we see is that patients with an underlying diagnosis or condition of migraine will present with headache.
Mm.
And then there are those who, have not had headaches and they present with headache. But then what we see is that those with migraine, they actually do very well
Mm.
because they recognize it and they get adequate treatment. But there are individuals who will get headache, never had headaches before, will get it during COVID, and that will persist.
Right.
And if you look at those patients, the symptomatology of those headaches are
A
migrainous
migraine.
or
Mhm.
migraine, and so we tend to treat those patients as if the patients have migraine because they have those the characteristics of migraine, and then they get better.
Mhm. Yeah, I guess I thought about that right as I was getting ready to wrap, because I have seen quite a few people who didn't have a history of chronic headaches, that developed COVID-19 infection and began to have
It's
basically
the same.
migraines,
Yes.
post-COVID. And some of them have resolved, after several months, and some of them have persisted,
Correct.
for long periods of time. So I think
Yeah.
that's important to recognize too.
It is. And I think you also mentioned that there are patients who come in and they said they've been on everything. And I
Mhm.
always challenge patients because I have a list of options for patients and it's like 2 pages. And
2 pages.
I'm
Have
like,
you
you've
really been
really
on
been on
everything?
everything. And remember, migraine it's a marathon. It's not a sprint.
Mm.
So it takes time for medications to work,
Right.
some of the
Right.
newer agents, not so much, but it does
Mhm.
take time and an adequate trial in order to consider a migraine treatment failure.
I tell all my patients, everybody's like Kentucky Fried Chicken. They all have their own secret recipe, right?
Yes,
So your
that's exactly right.
recipe is not going to be the same as somebody
That's right.
else's. And then what I also find is that sometimes people will have been on a medication and maybe not had enough of a trial in terms of the dosage or how
Correct.
long, so they're like, oh, I took it for 2 weeks and it didn't make it go away. So I
Correct.
stopped, so that isn't necessarily a failure. It just means we can find the right combination necessarily for you.
Correct.
So,
And I exactly. And I've had patients that say, "Oh, I tried it and didn't work." Well, what they were trying was a preventive medication, not understanding that it's not something to stop a migraine. So
right.
knowing the difference between what is an abortive treatment versus a preventive treatment is also important.
Yeah, absolutely. So, what advice would you give, to those? So, I always love, one of the reasons I started Brain Chat is because I want to empower people in the community to advocate for themselves, for their loved ones, if they're living with chronic conditions like MS or like chronic migraine. What advice would you give to those who may be dealing with headaches that have not been diagnosed or are not being adequately managed?
Yeah, so I would say talk to your primary care doctor or your healthcare provider. Start
Hmm.
there because I think oftentimes you may feel like, oh, well, they don't have time for that. Bring it up and say, hey, I really want to discuss it at the next visit. If you don't feel like you are getting adequate attention, or if you, I always encourage patients to seek out a headache specialist
Hmm.
if that's the case, if you're not getting adequate relief. And I would have individuals go to the UCNS website. There's a list of headache specialty providers in your area,
Hmm.
although
What is
there's a lot of
UCNS?
yeah, UCNS, United Council for Neurological Subspecialties.
Mhm.
If you go on there, it'll have a list. Just look at headache specialty providers. It'll have a list of headache specialists in your state.
Mm.
And you can go out there, or you can ask your doctor to refer you to somebody for a second opinion or for headache specialty care as well. And there's also resources that you can look at online. So the American Migraine Foundation has a list of resources for patients. And also the American Headache Society has an educational resource specifically for primary care providers that has updated tips and answers to questions related to diagnosis and management of headache.
Mhm. Yep, so do your research. Listen, we
Yeah,
do research for everything else.
yeah,
If we wanna get our nails done, if we wanna get a new hairstylist, if there's a new renovation we wanna do in our bathroom, we do research, right? So it's
yeah,
also important to do research about tools that you can use, to help yourself and to help your health condition, and it's also important to get that information from vetted sources, from reliable sources, right?
yeah.
Because everything you read on the internet is not necessarily true.
That's right.
Yeah, and so, what I would say, is also, to think about those lifestyle modifications, as we discussed, getting, the correct diagnosis, having a provider who can tell you about your options, but also making sure that you know the importance of lifestyle modification is extremely important, right? What
Yeah,
can we do to decrease that stress? Can we get that body moving? Can we get a little exercise in? Can we get adequate sleep? The majority of the time, right? Each of us, we all have days, where we don't, but can majority of the time we try to be on a schedule, right? How can we avoid those things that trigger, that headache so that we don't necessarily have to take medicine? And so
yeah,
I think that it's empowering to know that there are things that you can do even with a chronic condition like migraine to help yourself, just
absolutely.
like with multiple sclerosis. So, thank you so much for this wealth of wisdom. Listen, I learned something today. I was jotting notes myself, and I know that our audience learned a lot. Thank you so much for sharing, and for, discussing this really important topic that affects so many people. And I even see some people in the comments in the chat saying they didn't know they had migraines, they had headaches. So, for all of you out there, those hungry headaches, those sinus headaches, those
Yeah,
stress headaches, right? Get it checked out. It
yeah.
may just be a migraine, okay? And there are things that we can do about it. So thank you so much, Dr. O'Brien, and we hope to see you back soon. Thank you all to our audience for tuning into Brain Chat, and we'll see you again in 2 weeks. Have a great one, guys.
Awesome. Thank you. Bye
You're
bye.
very welcome.